neurology, neurosurgery, ortho, spine surgery, psychiatry, and neuropeds. إن شاء الله بعد residency, you will be a board certified physiatrist in which you could work in a private rehab center or in a tertiary hospital. طبعا sub-specialties. في sub-specialties كثيرة منها neuromuscular medicine involving neuromuscular diseases, pain medicine. طبعا هذه ممكن يدخلون مثلا من الفاميلي also وحتى من anesthesia. Pediatric rehab medicine, spinal cord injury, sports medicine نفس الشيء ممكن يدخلونه من الأورثو والريهاب أو من الفاميلي ميديسن وهو competitive صراحة. brain injury or traumatic brain injury, hospice and palliative care نفس الشيء أظن هذه ممكن يدخلونه بعد الميديسن. MSK spine, stroke, MS or multiple sclerosis, neuro rehab involving other neuro diseases, electrodiagnostic medicine, cancer rehab, occupational and environmental medicine. وطبعا في اشياء ثانيه اللي ما هي accredited بس اشوف يعني في ناس يطلعون fellowships فيها مثلا fellowship in spasticity. في other non-clinical fellowships مثلا اللي بيطلع بعد ما يخلص البورد يطلع medical informatics, hospital administrative fellowship. يعني ما انت محدود بس clinical fellowships. طيب الريهاب تيم سبيشال لانه مو زي اي other teams، لانه بيكون عندك multi disciplinary approach للبيشنت. بيكون في physiatrists وهم الفيزيشنز، nurses، عندك physiotherapist، occupational therapist، neuropsychologist، speech and language pathologist، dietitians and social workers. طبعا كلنا نشتغل مع بعض، وصراحة بدونهم يعني ما نقدر نسوي أي شيء. كلنا نشتغل مع بعض بس عشان to improve the quality of life of our patients. طبعا as a physiatrist what you will do, you will create a rehab program for each patient with individual goals. طيب الحين مثلا جاك مثلا patient عنده خلينا نقول stroke، فيجيك patient stroke طبعا بعد ما نيورو يسوي له stabilization في البداية يجيك طبعا تسوي secondary prevention، DM control or blood sugar control, hypertension and blood pressure control. بعد ما تخلص هذا تسوي له aggressive مثلا physiotherapy للaffected side. إذا يحتاج neuro rehabilitation مثلا من neuropsych يعني depends. spinal cord injury طبعا depends على الليفل، بس mainly يفوكس مثلا على الباول and bladder، لأنه إذا كان في spinal cord injuries especially if there is an effect on bowel and bladder هذا فنركز عليها أكثر. traumatic brain injury عادة they recover well بس بيكون عندهم cognitive impairment فنشتغل على النيوروسايك أكثر، فيعتمد على نوع البيشنت. أو مثلا ortho bust hip arthroplasty طبعا في كذا precautions و instructions for rehab. طيب الريهاب عندنا في السعودية طبعا في بس منطقتين، الرياض والطائف. بالرياض في عندكم مركز PSMC ولا برنس سلطان ميديكال ميليتري سيتي اللي هي العسكري، وKFMC الملك فهد، وكينج عبد العزيز ميديكال سيتي اللي هي هو الحرس. في الطائف أظن بس في العسكري أو الحرس سنتر واحد في الطائف. أنا بتكلم عن الرياض لأن تجربتي من الرياض. طبعا في الرياض في 10 positions في الريهاب each year. generally ما هو competitive، يعتمد شوف لما يكون عندك 10 positions فيعتمد على السكورز اللي بيجيبونها، يعني اللي 10 applicants اللي قدموها. لو مثلا مرة جايبين هاي سكور بيكون لأن عدد البوزيشنز قليل بيكون competitive. depends on the year. سنتي ما كان competitive، أظن كان below 70 أو التراكمي حقت النسبة اللي أو اللي شو اسمه المجموعة أو النسبة حقت التقديم، فتعتمد على السنة. بس generally ما هو competitive وما هو مطلوب، ما هو مرغوب. عادة اللي يدخلونه ما يدخلونه رغبة أولى. طيب طبعا بتكلم عن على السنترز في الرياض، وليش انا اخترت مثلا العسكري. العسكري للي انترستد هو بيكون في هوم اون كول as a R1، تبدا من R1 في sponsorship. you will see a lot of war heroes. طبعا هذا من ناحيه الامبيوتيز، وفي good or excellent صراحه stroke unit. KFMC في in house on call for the junior years، يعني بتكون في المستشفى. الام او اتش sponsorship، يعني بيكون الراتب اقل ما في بدل السكن، بس في عندهم better exposure صراحه. الريهاب سنتر عندهم كبير وفي 100 بيت، بس بيكون في tough service. يعني بيكون very busy service. الحرس ما عندهم اون كول. الاون كول بيغطي الميديسن، وفي sponsorship بس ما في that kind of exposure compared to other centers. طبعا بتكلم عن job opportunities من ناحيه لما تتخرج ان شاء الله او يكون عندك بورد في الريهاب. طبعا يعتمد على الريجن. في الرياض في عندنا زي ما قلنا 3، وفي سنترز بدات تفتح، في بالشميسي، في بالامير محمد بن عبد العزيز، في قوى الامن اظن بيفتحون، وفي العسكري عنده بيفتحون ثاني. بس كل هذه اشياء كلها خطط، فيعتمد هل تنفتح يعني قريب، هل بيفتحونها قريب، ما اعرف، بس يعني تيس انه من نفس الوقت، فيعتمد. للي انترستد صراحه اهم شيء تدخل الماتش. اسم اللي اهم شيء. واذا تقدر تسوي الكتيف بالبريفير سنتر مره يفضلون هذا الشيء لاحظته. واهم شيء صراحه في الريهاب اللي الانترفيو، في اسئله معينه يحبون يسالون عن الريهاب. اللي اذا احد وصل هذه المرحله ممكن يتواصل معي. مش بعد تيك هوم مسج. لما انا كنت مكانكم صراحه يعني هذه الاشياء كانت يعني مهمه بالنسبه لي. طبعا الريهاب ما هو for everyone. it's okay to feel lost. طبيعي ما انك ما تعرف وش تتخصص وش بتسوي. تحس خلاص بعد الكليه ما ادري وش بيصير. طبيعي جدا. it's okay to be late. حاط على quotation double quotation a year or two، لان ما يفرق، ما هو سباق انك تكون consultant. it's not okay to force yourself in doing something you don't like. مثلا تدخل تخصص ما تبغاه بس عشان مثلا خلينا نقول بس عشان الناس يقولون انك انت داخل هذا التخصص او شيء، واخر شيء بتعيش حياه يعني متعبه. طبعا اهم شيء خاصه انكم بديتوا الحين internship، try to find your work and life balance. هذا شيء مره مهم to try to prevent burnout. وطبعا don't compare yourself to others. always compare yourself to previous self. and زي ما قلت it's not a race to be a consultant. ما ادري مين يستعجل على المسؤوليه. ف اذا عندكم اي سؤال او استفسار من ناحيه الريهاب او اي شيء ممكن تتواصلوا معي عن طريق الايميل. واذا في اي اسئله انا موجود.
العافيه دكتور عبد الله. already received some question in Q&A. السؤال الأول يقول how is this job market، يعني is it promising خاصة في future years؟
شوف في على السلايد اللي هو job opportunities، ما ادري دقيقة. شوف في المناطق الغير رياض في يعني في طلب شديد على التخصص. إذا من ناحية الرياض إذا ما فتحت ريهاب سنترز خلال السنوات القادمة ما راح يكون فيه إلا مثلا يا تشتغل في تيرشري هوسبيتال as يعني سينيور أو ريجسترار يعني بورد سيرتيفايد، أو شو اسمه تشتغل ببرايفت ريهاب سنتر. الآن أشوف بدأوا يطلعون بدأوا يسوون ريهاب سنترز برايفت ريهاب سنترز، في واحد جنب الجامعة. من ناحية هذا السؤال صراحة يعتمد على الخطط اللي الحين موجودة، هل بتنفذ بسرعة ولا لا، هذا الله أعلم، زي
ممتاز.
أي تخصص ثاني.
في سؤال ثاني what is the differences between a physiatrist and physiotherapist؟
physiatrist هو الفيزيشن اللي متخصص في الفيزيكال ميديسن ريهابيليتيشن. الفيزياترست هو طبعا يكون مسؤول عن المريض، هو الطبيب المسؤول عن المريض، هو المسؤول عن جميع الاشياء شو اسمه الميديكال ايشوز. ويكون في طبعا صعب اشرح لك لانه يعني التخصص يعني انا عارف ممكن يكون مبهم، بس بشكل عام هو الفيزياترست هو الطبيب، الفيزيوثيرابيست هو الثيرابيست اللي يشتغل على البريسكريبشن او اكسرسايز بريسكريبشن الفيزياترست يسوي. مثلا يجيك خلينا نقول patient post hip arthroplasty خلاص، طبعا عندك بتبدا مثلا range of motion خلاص، مثلا انت توصف كفيزياترست range of motion، الفيزيوثيرابيست هو اللي يسوي الرينج اوف موشن نوت الفيزياترست. هذا الفرق. الفيزيوثيرابيست يعني هو التك اللي او الثيرابيست اللي يسوي الاكسرسايزز، الفيزياترست هو اللي يصرفها وهو اللي يتابع.
Great. Another question. يقول I have no interest in neurology and I want to choose a specialty where I don't need to remember all these nerve tracts and brain areas. Is rehab medicine suitable for me?
صراحة هو الريهاب يعتمد كثير على الاناتومي، بس ما هو زي النيورولوجي، بس يعني بشكل عام اناتومي جزء مجزء، جزء لا يتجزأ من أي specialty. if you don't like nerves yeah I don't know، ما في تخصص كامل، فمو لا تترك تخصص بس عشان تكره شيء معين.
تمام. Another question. Could you describe your work day؟ يعني لو تقولنا يوم في الدوام عندك.
طيب الدوام يبدأ تقريبا خلينا نقول morning meeting يعني على الساعة 7:30. بعد المورنينج ميتنج شو اسمه اروح اشوف البيشنتس تشوفهم مثلا من ناحيه ميديكال ايشوز ار ذي ستيبل اور نوت، بعدها تشوف وين وصلوا من ناحيه الريهاب بروجرام اللي انت سويته، وتشوفهم في الجيم وتشوف ادائهم، وبعد ما تخلص اذا في شيء بتغيره اذا ما في شيء خلاص يعني ذاتس ات، ما في شيء ثاني. في الكلينيك في اشياء حلوه بروسيجرز مثلا بوتوكس انجكشن اذا كان مثلا في سباسيستي، في باكتروفين بامب او ريفيل، في بروسيجرز جميله نسويها. اكثر شيء البوتوكس انجكشنز.
اوكي. another question. ايش تنصح لمعدل جدا سيء من تجربتك؟ يعني اتوقع هو interested في الريهاب والمعدل ما يساعده.
ايه الريهاب ما هو كومبتيتيف. سوي الكتيف او سوي الكتيف ما ادري، سوي الكتيف وشو انترست، واهم شيء تدخل الماتش. اسم اللي انا اشوف انه يعني وقتي ما ادري تغير عندكم، اسم اللي كان هو اهم شيء وهو اللي يدخلك في الماتش. بعدها الانترفيو عاد انت شطارتك يعني، لان تعتمد صدق على البريبريشن. فيا المعدل اذا كان معدل الجامعه قصدك ما هو بكثير.
اوكي. Is there any fellowship opportunities في السعودية خاصة؟
في السعودية لا، ما في كلام انه بيسوون ستروك ريهاب، بس يعني ما اعرف، بس اغلبهم يطلعون برا يعني. وفي فيلوشيبس كثير يعني اخوان سلايد فوق ال 15 او شيء زي كذا. يعني هذا الجميل فيه وين هذه كلها فيلوشيبس. طبعا التنافس على اللي هم الناس يبغونها سبورت ميديسن طبعا. ايوه.
طيب في سؤال يقول كيف قدرت تعرف أن التخصص مناسب لك؟
سؤال جميل صراحة. ما عرفت، أنا قدمت وش اسمه قدمت على معها زي ما يقولون، ما كنت أعرف إيش أبي، كنت أبغى GS. بعدين اكتشفت في الانترنشيب إن لايف ستايل ما هو مناسبني أبدا، فجربت أغلب التخصصات. يعني أتذكر جربت كل التخصصات منها راديولوجي، شفت باثولوجي، شفت ديرما، شفت كل الأشياء هذه اللي ما تخترع يعني. على حتى يعني جلست مع باثولوجيست يمكن اسبوع بس اشوف وش حياتهم وكذا. في الاخير يوم رحت الريهاب يعني سويت معهم كذا راوند، ما اخذت الكتف. حسيت ان هذا المكان اللي انا بشتغل فيه يعني اللايف ستايل جميل، ريواردنج من ناحيه الشغل، يعني تشوف الناس يتحسنون، البيشنتس ميديكال ستيبل، في جود excellent work life balance. لسه تخصص جديد في مجال للتطور كبير من ناحية يعني دفعاتنا والدفعات الجاية إن شاء الله. فعشان كذا أنا اخترت التخصص. وغير كذا في جانب ثاني إنه أوكي أنا معدلي ما كان مثلا يعني يمكن أدخل ماتش على ديرما، بس مستحيل أدخل ديرما لأنه كومبتيتيف. ففي هذا كان جانب ثاني يعني لأن الريهاب ما حد يبي، فهذا كان بعد من الفاكتورز كيف عرفت أن التخصص مناسب لي. بس الحمد لله الحين أنا صار لي سنة وأنا أشوف أن هذا أكثر تخصص الحمد لله مناسب لي.
ممتاز. Is there rounds and inpatient or all of them are outpatient?
لا، في راوندز inpatient وفي outpatient، في كلينيك
أوكي ممتاز.
وفي consultation، يعني كل شيء.
What are the less competitive specialties؟ أتوقع يتكلم بشكل عام، ما أدري بحكم تجربتك يعني.
على سنتي ريهاب كان منهم. وش كان بعد؟ بس في على سنتي كثير ارتفعت، مثلا فاميلي ميديسن أتذكر ارتفع، أغلب التخصصات ارتفعت، بس الريهاب كان ما هو competitive at all.
ممتاز. في سؤال تعقيبا على الراوندز، قال what do you do in rounds؟ يعني هتشوف patient يكونوا منومين في المستشفى
أيوة. فحسب ال kind of patients. إذا في medical issue يعني تسوي لها follow up، إذا ما في شيء تسوي follow up للبروجرام حقك، تشوف إذا في تحسن وإذا في شيء بتغيره. بحن بيصير في medical issues، مثلا يصير عنده spasticity تعالجها، new issues، يعني كأنه internal medicine بس داخل في الفيزيكال سايد أكثر.
ممتاز. نصائح للي بيفكرون في الريهاب، إيش ممكن يسوون خلال الانترنشيب يزيدون من فرصتهم القبول في حال يعني صار competitive specialty؟
أول شيء يفكرون في الماتش. أنا أنصح إن الحين لسه باقيين تختبرون سملي ولا خلصتوا؟
لا لسه، حنا
يعني
تونا
لسه.
fifth year، يعني بنبدأ الانترنشيب نهاية السنة.
أوكي. أهم شيء سملي لأنه يعتمد عليه، لا زال 50% هو.
إيه
إيه
5.
إيه، فأنا أنصح صراحة تركزون على سملي لأنه هو بيفتح لكم فرص. بعدها do an elective any preferred specialty، يعني preferred center sorry. show interest وخلاص، يعني ما هو competitive. حتى ما جوني انترنز الا واحده اظن خلال السنه اللي فاتت. يعني
شكرا
لا
جزيلا.
تشيلون هم من هذه الناحيه.
يعطيك العافية. anything to add؟
ما ادري، بس اقول الله يوفقكم ان شاء الله. اعرف وقت شويه صعب بس بتعدي، وسنه انترنشيب ترى هي من اجمل السنوات. حاولوا تركزون في المذاكره بعدين تستمتعوا ولا تشيلون هم، يعني كل واحد له طريقه، يعني ما هو سباق زي ما قلت. كل واحد إن شاء الله بيدخل ريزيدنسي، أو اللي ما يبي يدخل ريزيدنسي ما يدخل ريزيدنسي، واللي بيصير استشاري إن شاء الله يصير استشاري. أتمنى لكم التوفيق.
بإذن الله وياك يا رب. شكرا جزيلا مرة ثانية.
عفوا، ما سويت شيء.
السلام عليكم.
وعليكم السلام، حياك الله دكتور.
حياكم الله، مساء الخير، آسف على التأخير.
مساء النور.
I'm just trying to connect the link, it didn't work. طيب ثواني بس. Can you see the screen?
Yes.
طيب ثواني بس. طيب السلام عليكم، مساء الخير جميعا، الصوت واضح؟
واضح دكتور.
طيب can we start?
Yeah, we can start.
طيب بسم الله الرحمن الرحيم. I'd like to welcome you all to talk about the urology training program for those who are interested, and also to help others who are looking for future careers and specialty, to enlighten them about the specialty of surgical specialty, specifically urology here. So I'm the program director for urology for the last 40 years, and I'm a fellowship director for pediatric urology. And to start, urology is a field of, it's a surgical specialty. Currently, it's done in a separate training. In the past, it was done after general surgery, and nowadays it's done in 5 years program, followed by a year to 3 years of fellowship. It's a specialty that covers diseases that can be treated surgically and medically, and also it treats males, females, and also children. When we talk about this specialty, it's a dynamic specialty, and that includes dealing with disease of elderly, disease of young, disease of adolescents, and also disease of mid-age. You can decide to do general urology, which usually done just after training, or if you want to do subspecialized training, then you have to do extra year to 3 years. And the current trend in all surgical specialties is people are getting more subspecialized, and also this helps them to buy time to find a future job or their dream job in the future. Also, there is a high potential for research if you would like to work in the academic environment. If you like to do office-based practice, urology is the field where you can do lots of things in the clinic, including minor procedures, including cystoscopies, ureteroscopies, invasive testing like urodynamics and things like that. So it includes some things that you can do in the clinic without going to the operating room, and also it includes major surgical options. So the subspecialties we have in our field are variant, including pediatric urology, oncology, male infertility, sexual dysfunction, stones or endourology, female urology, which usually deals with incontinence and female urinary tract issues, neurourology, which deals with neurogenic bladder, especially in patients with spinal cord injury, spina bifida, or any other neurological issues. Or you can decide to be a general urologist, which is another option just after the training. The scope of practice, as I mentioned earlier, it covers medical and surgical treatment options. The surgeries of urology starts with open surgery, which is the traditional way of doing things, but also we have the variety of minimal invasive, including laparoscopy, endourology, which mainly done with ureteroscopies, cystoscopies, or percutaneous nephrolethotomy. Some can be done under local, others can be done under sedation, and the remaining can be done under general anesthesia, and the majority of the time these are done as a day surgery. Robotics is another field of interest in urology, and urology is one of the commonest specialties uses the robot. And if we look at the statistics of robotic use all over the world, urology always scores #1, and after that other specialties including OB-GYN, cardiac surgery, and general surgery. But urologists are the commonest or the highest specialty use of robotics, mainly in prostatectomies, pyeloplasties, and other reconstruction procedures. And as you see in the pictures here on the left, this is a cystoscopy or ureteroscopy done for a patient with the use of fluoroscopy and X-ray, under fluoroscopy and X-ray. In the second picture, you can see this is a laparoscopic procedure, and this is seen in urology, general surgery, obstetrics and gynecology, and laparoscopy is the future. Minimal invasive is the future of all surgeries. We tend not to do any open surgeries anymore, and in urology, you get exposed to this in training, and also we expect you when you graduate to be able to do the common procedures like nephrectomies and things like that. And in the third picture, you see this is a patient who's getting robotic surgery, and you see the surgeon and the counsel away from the patient, and his assistants are close to the patient. And this gives you the advantage of, first, you can do very fine surgery, you can do very challenging surgeries where if the space is tight, or even the ergonomics where you cannot move your hand more than 180 degrees. In the robot, you can do 360, you can do things backward, forward. It gives you the flexibility of movements, and also it clears the fine moves and the tremors in your hand. So the robotic surgery is one of the top-notch or top technology procedures nowadays. Outcomes in patient relationship. The outcomes in urology for patients, usually it's very satisfying. We tend not to have chronic illnesses that stays with the patient, and every specialty has some chronic illnesses like fibromyalgia in neurology, or like migraine, headache, or chronic back pain for neurosurgery. So we do have some chronic illnesses, but the majority of the disease we deal with are whenever you do surgery, things get better and the patient will like you, and it's very satisfying for us and for the patients. Lifestyle as a urologist. In residency, it can be busy, and I think if you're not busy in residency, then you're not in the right training center. So all surgical programs are busy during the training period, and you should keep yourself busy during training by getting exposures more to more cases, more patient encounter, and also more experience by dealing with different cases, looking for extra cases, discussing cases with your seniors and with your superiors. Lifestyle after training, it's great. It's quiet. It's not like general surgery where you have to come in your 40s, 50s, 60s and doing appendectomies and cholecystectomies and trauma. Usually during call, it's quite the commonest emergencies we deal with. It's mainly renal colic, which can be treated conservatively. You can admit the patient and treat the patient next day or after a few days. So no rush to do anything. Retention is another emergency we deal with, and usually the trainees can deal with it by just placing catheters, or suprapubic catheter or Foley catheter. So the chance if you come into the hospital as consultants are very low, but it's there. Torsion is another emergency we deal with as a urologist, as pediatric urologist, but still not very common. So it's lifestyle in terms of call is not bad. In terms of practice, it's still very satisfying. In terms of load, it's very satisfying too. It's a busy in private and public sector, and there is need in the country for such specialty. Social expectation. I think now all surgical specialties are socially acceptable, and we'll talk about the females doing urology also. Now it's a trend, so we'll talk about that in the next few slides. So residency program is a 5 years program. Usually the first year is done in general surgery. You have to do 3 months of ICU. You start with urology from second year all the way to the end of 5th year. Usually the 4th year done outside the hospital that you were working with, and the remaining will be done in the same training center. So it's not a rotation program, it's not a joint program. It's under the umbrella of Saudi Commission for Health Specialists. We in our center we take 2 trainees per year, and we have 10 at a time because it's a 5 year, so we have 2 in each level. Lifestyle, as I mentioned, it tend to be busy in residency. The call usually it's home call. rotation, as I mentioned already, vacation. Usually in all programs it's 1 month in each year. When you choose your surgical program, you have to do your homework first. Find, does this lifestyle fit you? You have to do electives and see how's the trainees and also how's the attending consultants performing. Do you see yourself doing that for the next 10, 20, 30 years? How's the surgical exposure in the center of interest? How's the volume? What's the type of cases? You have to be in a place, if you have the choice, you have to choose a place where you can see all the variety of cases. Number of consultants is a key factor when you choose your surgical program, because some programs has 2 to 3 consultants only, and I think your exposure here will be limited. So you want to have more than that if you have the choice to see different schools and different way of doing it. Also look for the subspecialty. If you're interested to the specific subspecialty, also it's good to be in a place where you get exposed to such cases. Fellowship opportunity, if you're thinking to do a specific fellowship, if you train in a place where they have the same fellowship, it increases your chance of acceptance in that fellowship. Training centers in Riyadh, it's 9 centers already. It's plus minus because some centers now are on probation, but the big hospitals usually consistent. They take specific number per year, which usually الجامعي والحرس الوطني والتخصصي والعسكري وقوى الأمن والشميسي ومدينة مكفأة الطبية. هذه المراكز الرئيسية اللي فيها تريننج. وعبد الرحمن الفيصل الآن موقف، محمد عبد العزيز الآن موقف، وعبد الرحمن الفيصل موقف، سلمان أظن كما بعد موقف. طيب, numbers in Riyadh, as I said, it's fixed, plus minus. Those programs are suspended now, so around 25 to 28 per year, and usually it's competitive. The average overall mark for the people who matched last year was around 75. Is it a male specialty? This is a common question we get asked nowadays, and actually over the last 5 years we start seeing more females getting accepted in urology. Started in the east, then in the west, and now in Riyadh too. And I think it's becoming not a male specialty, it's becoming both for males and females. Looking at the literature in the US, the percentage of female urology residents has increased over the last years, starting from the 80s currently to more and more. And also this happened in Canada. So a recent study looked at gender difference in the US, found that females were more likely to do fellowship in female pelvic surgery after they finish, or do pediatric urology to make it more appealing for them. So they do the general urology training, then they specialize either in pediatric or in female urology. And in our country, female urology is very needed. And if you end up doing it as a female, you will be very busy, and it's very satisfying specialty. In Canada, the same thing. They looked at the numbers of females who matched the urology program, and as you can see, the curve is going up, and now it's steady. So, do I do local or a training or an international program going abroad? And I think this is the $1 million question. Some say from the beginning, I don't want to do any local training. Others say I'll do local training, and if I get opportunity to do overseas training, then I will stop my training and leave. Problem nowadays is sponsorship for scholarship, and if you work in academic setting or a university, usually they would prefer that you go abroad and do training. So you have to measure the pros and cons of each steps. For a while, there was no training in Canada with the political issue, but nowadays it's resumed. So we have the US, Canada, and Europe, and you can find training there. So I think there is opportunity nowadays back to the previous days, because now people start go to Canada again, but it's still the issue of finding a scholar who sponsor your scholarship. Then the remaining will be just general advices, personal interview. When you interview for a specialty, you have to be yourself, be calm, don't lie. People read the CVs, so your CV talks about you, so make sure you put good CV together. Work hard for it. You have to come prepared. You have to do electives. The first question I ask people when they match, if they haven't done an elective, why did not do any electives in urology? And you tend not to be appealing for any program if you didn't do any electives, or if you did one elective only and the remaining are done in other specialties. It shows that you're not interested. And even if you didn't, make sure you have an answer for that, because some people change their mind in the last rotations or last minute and change the specialty. So make sure you have an answer for that and say, I was interested in that, I did it for a while, then I did not find myself in it. And I think I found myself in urology because I did more in medical school. I spent time with them. So make sure you have an answer for that question if you didn't do any electives. Research is a key way to help us to choose our candidates, especially in the area of same specialty. Build your CV well, make sure you have good letters, make sure you do service rotation. If you finish your training and you did not match and you want to match for the next year, make sure you do service in the specialty of choice. Personal skills, I think you have to prepare yourself for the interview, and this takes that you know your CV well, making sure that you have answers for the commonly asked questions. The CV, always make sure that it shows your interest. So if I'm building a CV for general surgery, then I would reorganize things backwards. So I put the general surgery stuff higher in my list, for research, for electives, and put urology under. And if I'm interested in urology, when I apply, I will reorganize and reorder things. It shows urology things in the top, then other specialty in the bottom, because sometimes the visual people can look at this differently. So always try to rearrange your CV depending on what specialty and what center you're applying for. For example, if you're applying for the university hospital, make sure you put things that you did electives in the university, put them high in the in order, and also put your research for JAMA, your electives for JAMA. It just reorganize things and reorder things accordingly. It shows, for those people who are visual, it gives them like a hint that you're interested. There's no single right way to write a CV. Just make sure it includes your academic performance. It includes things that shows you're interested, and also it shows that your personality too. So in any training program you choose, make sure first know that program well, because they might ask you about it in the interview. Where would you like to be? في الماتch, if you match in urology in Riyadh, what's the number one center that you would like to match in? And expect that question, especially in the places where you didn't spend time with. They will ask you this question, so make sure you have an answer for that. So this is it for today, and I'm happy to answer any questions.
Thank you so much, Dr. Fahad. Already received some question. السؤال
Yes.
الأول, will female have less exposure if they choose urology, especially because of gender barrier?
Of course not. There will be some social barrier, especially from the trainees herself. Patients doesn't have the choice. Knowing colleagues who went through this and now they're shining stars in urology, there will be some, there was some social barrier, but nowadays I think things are changing, especially with how things are going in the country, and also that few people went through it. And I suggest and advise for any females who are interested to do urology to speak to females who went through this. And there is few, and we can suggest names.
Great. Another question, can you explain the journey until get to pediatric urology? يقصد من الريزيدنسي للفellowship.
Hello?
Yes, doctor.
Sorry, I get disconnected. So anyway, I suggest that they should speak to doctors who went through this, and we can suggest names. يعني في الرياض في دكتور صار محيسن في جامعة نورة، الشرقية في دكتورة مها الماضي، وفي another two doctors, I don't remember their name offhand. في جدة في دكتورة ميبة نخر. الآن in training there is few residents, National Guard in King Faisal. So I think they should speak to them and see their experience. And I'm sure they will not hesitate to give them their insight. And it doesn't hurt that they should go and talk to those people who are going through it now, or people who finished it. At least it gives them different perspective than what I give them as a male urologist. but we see it more, and I think it's becoming يعني very appealing and becoming يعني one of the areas of interest for our new graduates.
Great. Other question, can you explain the journey until get to pediatric urology?
Sure. So to be a pediatric urologist, you have to go through urology training, which is 5 years. And I think if you're interested in pediatric urology from the beginning, you can ask your program director that he can do more rotations in pediatric urology. You have to, of course, know the disease more because you're interested in that any area, and also show interest, so it prepare you for the fellowship. So attend the pediatric urology activity that we have on a monthly basis, try to do research in pediatric urology. All these things will make your chance of acceptance and fellowship higher, and also it shows that the people that you're interested in, you're goal oriented. So we rarely see people who decide the subspecialty early on, and if you decided that early on, make sure you test that very well, make sure that fits you. And if you say today I want to be a pediatric urologist, if you spend 5 years in training and you did that rotation in different hospitals and you get exposed to it very well, at that point you can decide, because it's very early to judge early on before even starting residency that I want to do X subspecialty. I think this is amazing, but make sure you test that well. And do you see yourself doing it? So you might change your mind halfway through the way or even at the end. But I think if you like it, you will make yourself liking it more. So, which is like you're passionate about something, then you would do more, read more, and do more research in it. So, I think this is great, but make sure you test that theory well.
Perfect. Another question, we heard that you accept males more in urology and ortho and make it hard for girls. Yeah, is that okay or right? Or...
I think this is changing. I've been program director for 40 years, and the numbers are increasing every year. The number of females who match in urology, especially in Riyadh. I don't know about the other areas. So if we look at the numbers, I think you can come up with such conclusion, because there's more males match. But I think the Saudi council system, the match system, make it more fair, which means it's done by dummies. الناس اللي يسوون الماتش ناس في مكاتب ليسوا أطباء ولا عندهم أي خبرة في وش معنى يورولوجي. they look at points and they match the people who are more points toward the specialty. هل هذا كلام صح ولا غلط؟ مو موضوع نقاشنا. I mean, the system it's built now, the system that the Saudi Council built, make it less biased, which mean في الرياض عدد المراكز لنفرض يعني نقول 9 مثلا ولا 8 ولا 7، وعدد البوزيشنز تجمع المراكز وخلاص، نقول ترسل للهيئة ان عدد المراكز X وعدد المقاعد في الرياض 28، خلاص then they match 28. For those people who match are gonna be in Riyadh. For that's mean your chance of being accepted as a girl, if you match in Riyadh, it's there, except if you didn't do well in the interview, because each program عنده الفرصة to exclude 10% من المتقدمين. وعادة الاكسكلوجن دان بيست على السي في. يجيني واحد السي في حقه صفحة واحدة ولا في أي شيء له علاقة في اليورولوجي، وعندي chance to exclude him، أقول هذا حتى ما أبغى أقابله في الانترفيو، then I would exclude you بغض النظر أنت ميل ولا فيميل. لكن I think the point system increase your chance of being accepted في الرياض ولا في whatever يعني whatever area، بس it increase your chance لأنه done by dummies والباقي عليك عاد. يعني let's mean you will match in Riyadh، خلاص there is a 90 to 95% you will train in Riyadh، نقطة على السطر. فالباقي خلاص بيدك how you do in the interview. And if you're a female, expect this question. Would you feel يعني بيجيك سؤال كذا بس to test. They don't want people to drop out of the program halfway through. And knowing it's a specialty deals with majority of male problems, even though we see female and we see pediatric, but the majority are males. They might ask you this question just to see that would you survive this. أو ممكن يسألوا يقولك هل سألتي شفتي ناس مرة بالتجربة هذه وش كانت تجربتهم. They want to make sure you tested that. يعني ما جيت اليورولوجي إلا أنت مقتنعة بالتخصص. لكن I think the new system it make it more fair in terms of numbers. يعني الماتش مو بيدنا ولا بيد أي program director. تجينا من فوق من الهيئة خلاص these are the people who matched. وخلص. عاد الباقي بيد البروجرام دايركتور وبيد المتدربين وبيد الناس اللي في الانترفيو. بس لنفرض انه في الرياض قبلوا 20 و8 منهم فيميل، هذول 100% بيكونون ماتش في مراكز كبيرة. يعني no way انه يعني if they get to exclude واحد أو واحدة، لكن ما they cannot exclude the 8. Plus we've seen very strong candidates I have to say. يعني ناس قدموا السنتين اللي فاتت female يعني صراحة كانوا very impressive. they showed interest و they match في التخصصي وفي الحرس، وهم أكثر برامج competition. I think this changed.
ممتاز. كان في كذا أسئلة عن نفس السؤال، إنه هل في ممكن difficulties تواجه الفيميلز خصوصا خلال الانترفيو؟ يعني الماتشنج سيستم زي ما قلت يعني بيكون بلايند، ما راح يفرق بين الميل والفيميلز، لكن after that من ناحية السبورت في الورك اريا والأشياء اللي زي كذا
Trust me, if you match in a place, المكان will support his trainees to the max. يعني after you get accepted في program خلاص ما you cannot ما تقدر يعني تعامل الترينيز بطريقة مختلفة، لأنه السيستم built إنه أول شيء it's service based plus في جزء educational يعني مدراء البرامج والمدربين مسؤولين عنه أمام الهيئة وأمام المتدربين وأمام البرنامج وأمام طبعا ربي. فما حيكون في variation في التريننج، لأنه أنت بتكون assigned في service فيعتمدون عليك. they cannot give you less because they want you to do more so they can depend on you. So system built on trust. But if you don't gain people trust because you're not working hard for it, هل أنت male ولا female, this will not make a difference. Whenever you're accepted, هذا السؤال خلاص تقفل. هم committed to you, أنت committed to them. They want to make sure نجاحك نجاح لهم ونجاحهم نجاح لك.
ممتاز. قلت أن الأكسبتنس الحين من البيشنت صار أحسن، يعني فهل الفيميلز ما راح يواجهوا معهم صعوبات حتى في المستقبل؟ بيكون يعني البيئة أفضل من الناحية هذه؟
يعني خلينا نكون واقعيين. أنا erectile dysfunction clinic patient might feel ashamed. طيب بس I've seen situations where a trainee prove herself أنه no يعني في بعضهم من البداية يعني avoid such يعني encounter، يعني تتفادى الكلينيك هذه which I don't think it's right. طيب لكن I think if the patient asks, the patient has the right. وأحيانا الكونسلتنت يقول لك لا والله هذا متدرب معانا في البرنامج، بس أحيانا يعني this rarely happens and I don't see this happens. Plus يعني if you're not interested في الاريا هذه at least you get to expose to it, you discuss it. على حسب المراكز، في مراكز ما فيها these type of patients anyway. I don't think you should put this as an obstacle. يعني إذا واحد بيدور سبب إنه ما يدخل برنامج بيلقى سبب. هذا كلام في كل البرامج، نفس الكلام على الأورثو، نفس الكلام على الأوبيجايني. يعني if you find such excuse not to choose a specialty you will find it في كل التخصصات.
ممتاز. في سؤال: مع ظروف الجائحة ما قدرنا نسوي إلكتيف والآن بقي فرصة واحدة لنا، فإيش تنصحنا؟ يعني خاصة لو واحد عنده more than one interest.
يعني it's unfortunate، هذا شيء خارج عن الإرادة، وأتوقع مدراء البرامج ماخذين هذا بعين الاعتبار. لكن you should have other areas that shows your interest. يعني قصدي elective ما أتوقع أنا كمدير برنامج السنة هذه بيكون exceptional. يعني بكون متفهم ليش ما سويت عدد من الإلكتيف. لكن إذا جتك فرصة في الاريا of interest ما سويتها يعني تقلل فرصتك. لكن there should be other areas including the research, including the conferences, including the participation في social events related to awareness. فقصدي في too many areas compensate for this. بس السنة هذه يمكن استثنائية ويمكن أكيد أثرت على كل التخصصات وكل المتدربين، فطبيعي أن نقدر الشيء هذا.
ممتاز. أي نصائح للي ناوي بإذن الله يقدم على اليورولوجي؟
show interest, spend time with الاريا، يعني المكان اللي تبغى تتدرب فيه. do elective في المكان اللي تسوي فيه. always have a plan B specialty. you can always have a specialty that you can transfer. يعني قصدي إذا بتسوي general surgery تبغى urology, if you match in general surgery لأن السنة الأولى general surgery يعني decided to change at the end of the year, أعطي نفسك خط رجعة. always يعني I would say work hard for it. من medical school have a mentor في الاريا of interest حقتك. يعني show interest early on if أنت عارف إنك تبغى urology من سنة ثالثة. يعني do research, attend activity, show people that you're interested, to make them more familiar with you, and also يعني to put you on their map early on.
اوكي ممتاز. في عندي هنا سؤال يقول can I have recommendation letters سواء during لو أخذت معهم elective أو بدون؟
طبعا ما حد يعطيك recommendation بدون ما يشتغل معك يعني الأمانة. و recommendation letters يعني مدراء برامج ياخذونها بشكل جدي. when someone comes with a strong recommendation letter it means he spent time with X and Y, especially إذا أنت جايك خطاب من مدير برنامج it shows إنه ترى مدير برنامج هذا interested in you. وأحيانا بعض الخطابات التزكية تكون لهجتها قوية إنه فلان ممتاز مرة أو فلان عادي. يعني أحيانا الخطاب في خطاب يكون جينيريك I would recommend him for any training program he choose ما فيها شيء يعني shows إنه you're interested in urology. لكن بعضها يقول لك he spent time with us in urology و I would if he applies to my program for urology I would take him for sure. يعني shows يعني قصدي قوة الخطاب هذا شيء مو بيد المتدرب ما يقدر يحط المحتوى. لكن أحيانا خطابات التزكية تعطي يعني good impression عنك. if you can get a recommendation letter from people who are specialized يعني يجونا ناس للأمانة ما عنده ولا recommendation letter من urologist كلها general surgeon و ENT وما أدري إيش. طيب يعني you spent 3 electives in urology ولا عندك ولا خطاب تزكية then either you did bad وأعطوك أعطوك recommendation ضعيفة وما حطيتها في السي في حقك أو ما طلبتها وهذه تقصير منك أو إنه أنت قاعد you're hiding something لأنه you didn't do well and you're hiding it.
ممتاز. Thank you so much Dr. Fahad. Anything to add or advice يعني
موفقين خير وإن شاء الله نشوفكم كلكم في أحسن الأماكن و looking forward to see people who are interested in urology and wish you all the best and thank you for the invite.
Thank you so much.
Welcome. Bye-bye.
We would like to apologize. Public health will be announced later and rescheduled. So we will have break time until 7 p.m. بإذن الله. السلام عليكم دكتور حاتم تسمعنا؟
ايوه اسمع.
حتبدأ الحين؟
اللي يريحكم انتم. Are you guys complete?
تقريبا يس.
اوكي. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين. My name is Dr. Hatim Nasser. I'm an assistant professor and consultant in internal medicine and nephrology, and I'm the current program director of internal medicine in KKUH. So I was asked kindly by your colleagues to speak today about the internal medicine program and answer a few questions about it if you guys have at the end of this discussion. So I did not prepare a PowerPoint presentation because I'd like this talk to be a little bit more interactive, and I would like to answer more questions rather than give you information, because internal medicine, as you guys may know, is one of the largest programs all over the world as a residency program. In Saudi Arabia, it is a 4-year program. How to apply is to go through الهيئة السعودية للتخصصات الصحية. You do your interviews with them, and once you're accepted to become a resident in the internal medicine program في مدينة الرياض, we get your guys' applications and we go screening through your applications based on your CV, your SMLEs, and go from there. So as a program, it is, as I said, 4-year program where you rotate through variant and different subspecialties of internal medicine. The structure is there are 2 years of junior years and 2 years of seniors. The junior years, basically, your role is to learn and understand the basic concepts of approaches and management and the basic topics in the internal medicine specialties. The main specialties that you rotate through are nephrology, gastroenterology, pulmonology, hematology, neurology, cardiology, infectious disease, rheumatology, and intensive care unit, and the cardiac care unit, which is CCU, and of course CTU. So you have to do the minimum requirement that the required you to do is 7 to 8 rotations as a junior in the CTU unit between your R1 and R2 years. And then when you become an R3 and R4, the rotate or a senior, the requirements are different. You also have to go through these specialties as a senior, but your role is different in the team. So your roles in the team as a junior is you'll be taught by your seniors how to stipulate a good approach and how to make a good management plan and to make sure how to follow up with your patients. You'll be attached to clinics and all the subspecialties you do throughout your all 4 years. There are some electives and selectives that are scattered throughout the years to see what you want to pursue in your future career after internal medicine. The good thing about the internal medicine residency program is that it opens a lot of doors after your residency. So the options are a lot after you graduate. So you can subspecialize in any of the subspecialties in internal medicine after the residency program. Or you can also continue as a specialist in general internal medicine, which also has a lot of potential. And there are not a lot of people that are doing the job these days. So one of the things about the internal medicine program as well is that as a program, because it is a big program, we do take more residents than other specialties, but it is still a competitive pathway or career to pursue. So, and the other good things is that it combines clinical thinking or critical thinking, and there's also a lot of teaching, and there is a lot of hand skills that you also need to use. So you still have specialties that you can use interventions such as gastroenterology, pulmonology, even nephrology. So there's a lot of procedures like line insertions and fistula manipulations. And also in gastroenterology, you can do endoscopies, colonoscopies, ERCPs, endoscopic ultrasounds. Cardiology, you can go through endoscopic ultrasounds, TEEs, cath labs. So there are hand skills that you can pursue in the internal medicine subspecialty residencies after your internal medicine residency program. The downside is it is tiring. It is a little bit hectic because you have to, by the end of your program, you still have to be knowledgeable enough to be a good general internist. So you have to know good amount about everything in most of the specialties. So it is hectic. There's a lot of reading. There's a lot of studying. And there are a lot of phone calls. So the other thing in what I wanted to talk to you about in our residency program is that I'm going to talk a little bit about the KKUH residency program compared to other programs. So our program, as you may know, is one of the largest program in the country. We take around 25 to 26 residents per year. Some people do continue, some people leave, but by the end of the R4, we graduate almost roughly 25 people per year. So that's that. And then after you guys get accepted, the teaching aspects of our program is that we have half days for juniors, where we basically dedicated for approaches and management. So we want to make sure that your approach and management skills are well done before you go into your senior years. The seniors have their half day more in literature review, new guidelines, and articles. So that's about that part. There's also teachings in the morning times. So Monday, there is a case presentation done by seniors and juniors, what good cases they've seen in the month prior in the ER, and presented to their colleagues, and they go through their approach and management. Tuesdays, we have grand rounds for medicine, general medicine, usually presented by consultants. And Thursdays, we have approaches that are done by seniors to juniors. And we also have once a month, changed this year, is we'll have in liaison with the ICU team, is that we're going to have clinical skills in the simulation lab. We're working on that right now, where we're going to work on learning line insertions, intubations, all the skills that we're lacking, doing it a day-to-day in our wards and in our subspecialty training. Okay, so that is the teaching aspect. We also have bedside teachings done by consultants. We also have dedicated teaching in the subspecialty units in the mornings after the teachings that are done by the general program. So this is the teaching aspect. Calls, we changed the format of our calls this year. So juniors will do 24-hour calls in the CTU, covering only CTU. They don't do the other specialties while they're doing CTU, so that's a change. The other specialties are divided. There are GI nephro calls, there are hematology oncology calls, and there are other specialty calls. As juniors, you still have to do 24-hour calls, but given the number that we have, there's not a lot of calls. As seniors, you do 12-hour shifts and overnight calls for medicine and other specialties. So that's the call format for our program. The other good thing is that in our program, we tend to meet with our residents every 6 months, talk about the concerns, talk about what can we improve in our program and what is going on in their day-to-day life. We also, it still did not happen, but we're working on it, is a mentor program given that this year is a little bit hectic due to the COVID-19 status. But we're going to assign, especially the juniors, to a specific mentor and continue with them throughout the years to help guide them through their pathway in choosing a good specialty. If there are any concerns during their training, they can help with that as well. So that is in the backup thing. From year-to-year assessment. So in all of internal medicine, the promotion exams have been cancelled by Al-Hayya Saudiya and has been replaced by the New England Journal of Medicine assessments. So you have to learn 500 objectives by the New England Journal of Medicine question banks every year. And we have added to that you have to do 20 objectives per week, other than what you have to learn. Also, there is mini CEXs, which is basically the consultant directly supervising you in either taking history, physical exam, data interpretation, or medical management, and that goes into your evaluation as well. There will also be end of rotation quizzes. It is a informal quiz that just makes sure that you know you learn the objectives that were given to you by the beginning of the rotation. Also, so this is the teaching aspect of things and the call schedules of things. So the downside is, as I mentioned, it is hectic, it is busy. You need to read a lot. You need to be on your toes for your patients. The CTU team can have up to 26 inpatients. But as a junior, you'll only handle up to 8 to 10 patients. But as a senior, you'll be responsible for all of your patients and all of your juniors. So there's a lot of responsibility there, and you need to be on your toes from that perspective. It is rewarding. It opens a lot of doors after you finish your residency program. So these are the main aspects of the internal medicine residency program. So I didn't want to talk a lot. I just wanted to hear more of your questions, if that's okay with the panelist, Dr. Shada.
Sure,
I'd like to hear.
thank you so much. Yeah, already received some question.
Yeah, so I'm gonna start answering one by one.
Okay, great.
So كم عدد الأطباء اللي ينقبلون كل سنة في تخصص الباطنة? So basically in our program, I don't know about Al-Hayya صراحة لأنه I did not go through the acceptance the interview process last year, but in our program we take up to 25. So we get more than 100 interviews, to give or take, but we take 25. 100, 150, we take 25. Does my grades in internal medicine med school reflect my ability to become a competent resident? Is there a chance to catch up? Yes. So for me, the fact that you passed the interview للهيئة السعودية وانقبلتوا في الهيئة السعودية في internal medicine program في الرياض, and you come to me as a resident, the fact that you passed them, I think you are a good enough resident to be a part of our program. And then small details such as interview skills, you as a person, if you've worked with us in the past in an elective or selective in your internship years, if you've done any research with us, if I ask around and people know you personally, how hardworking you are, yes, absolutely, you can still catch up, even if you did not get the great scores in internal medicine. اللي فيها حاجة الآن وبالسنوات القادمة sub-specialties وإيش التخصصات اللي وصلت لاكتفاء بالمدة الرئيسية خاصة. So it goes and comes in waves, okay? So the problem with this question is that, for example, there will be a year for the past few years, for example, cardiology and gastroenterology has been fulfilled. ولكن because of that, people will now, for example, not go into gastroenterology and cardiology because of this. So in a few years, there will be a need for them. So you cannot really know by the time you guys graduate from internal medicine what will be the need. So the need right now is going to be different from the need in the next 4 or 5 years. So keep your minds open when you do your residencies. Don't be narrow-minded to only the job market. Do what you like, because the problem with choosing a career pathway is that it's like bondage or partnership or marriage. You're stuck with it. You don't want to do something you may or may not like just because the job market asks you. You need to do something you like, because at the end, if you don't have the mind satisfaction at the end of the day, you'll not achieve the most that you can achieve as a person. It is important that I have a subspecialty in mind to pursue medicine. Absolutely not. And that's the reason why we do have the internal medicine program as 4 years. You rotate through all of your specialties. People do not choose their specialties unless by the end of their third, beginning of their fourth year. Otherwise, why? It's going in. As a matter of fact, going into the residency program, narrow-minded to one specialties and biased to one specialty, is going to be hard for you to focus and excel in all of the other specialties. So I prefer that you do not have a specific specialty. Of course, every person is different, but I prefer not to have a specific specialty going into the program, because if you do have a specific specialty in mind, you'll be narrow-minded going into the program. You'll not be open to other suggestions. You might actually like something else. So yeah, keep your mind open so you don't have to necessarily have a subspecialty in mind. Without being biased, since you're the program director, what is the best center in Riyadh? So I did my training abroad. So I don't think this is honestly a fair question, because first of all, I did not do my training here, so I wouldn't know what is the best center. But what I can tell you is that our center, I'm trying to change as much as possible to, in my eyes, become the best center in Riyadh. So I cannot answer this questions without a little bit of bias, but they also, to be fair, I did not do my training here for me to answer this fully. So I don't know about all of the other centers in Riyadh. And I just started becoming program director 6 months ago. So yeah, that's that. Can you talk about the lifestyle? Okay, so the lifestyle for internal medicine is a little bit different. So residencies in general is tiring. So wherever you go or whatever specialty you go through, most of them, I'm not going to say all of them, but most of them, it's a little bit hectic. There are calls, there's a lot of reading. You need to be on your toes for your patients. But the difference of lifestyle in internal medicine compared to other specialties is when you become an attending or a consultant, it depends on what specialty. So this is the beauty of medicine. So it depends on what subspecialty you want. There are very chill lifestyles when you become a consultant, even when you're on call. And there are subspecialties where when you're on call, you're on your toes. So for example, in cardiology, it might be very hectic and busy, and you might have to come overnight. For a cath, like with a patient that presents with an MI or tamponade, or a patient that is sick in your CCU unit. But for example, if you're in endocrinology, there are not a lot of things that would bring you overnight for you to come and see. It's a more chill, clinic-based subspecialty. So it all depends on what you want to pursue and what lifestyle you want to pursue after doing your internal medicine residency training. How to stand out in an interview? Be yourself. I want to be completely honest. People going through the cliches answers, we know in the interviews. We know that you've rehearsed. So for example, I'll just give you a very minor example. Please, when you guys go through the interviews, keep that in mind. So when I say talk about yourself, I don't care about your accomplishments or where you studied, because all of this should be in your CV. I should have read your CV before you came into my interview. I want to know the person that I'm going to be a partner with the next 4 years. He's going to be working with me and with my colleagues. I want to know this person, how this person, what do they do, what do they like, what do they dislike, socially, hobbies and all that kind of stuff. Because as academic achievements and personal achievements. This all should have been included in the CV. So you're just duplicating the work. So I really want to know you as a person. Don't be shy. Um, speak your mind in a professional manner. Tell us more about yourself as a person. These are the main things. And when you're put on the spot, it's okay. Don't feel anxious. Don't feel nervous. We have all been there. We've all been in your situation where we were in the interviewee. In the end, you will remember these days and laugh about them. So just be yourself. This is the most important advice I would give anyone for an interview. كيف طريقة مقابلات الجامعي? So depends on the COVID status, to be honest. COVID status made us do our interviews last year through Zoom. So in the Zoom meeting, there would be the program director, one of the associate program directors, and the chief residents, where we rotate asking questions and answers. But it might change depending on the COVID status. So if the COVID status is still the same, this is how it's going to be next year as well. Okay. What is the lowest accepted score last year? Honestly, I cannot tell you that because I was not in the panel last year, and I don't think it is a specific number. There's no specific number, I think, for it to be accepted. The fact that you've got accepted to internal medicine in Riyadh makes you a good candidate that you may or may not pursue. Then I would like to know the person. بالسنوات السابقة كان مو مسموح لنا ناخذ elective medicine غير متاح، والعام الماضي لما أصبح متاح انلغى بسبب الكوفيد. فكيف نقدر نجرب؟ This year there are electives in medicine. We're taking interns this year. They're doing all of the subspecialties. So now you can take electives in medicine, depending on availability of the internship program. What about fellowship programs in Saudi? How many are there? So there's a lot. So most of the subspecialties have fellowships in Saudi. So nephrology, gastroenterology, cardiology, rheumatology, endocrinology, infectious disease, pulmonology, critical care, all of them, they have fellowship programs in Saudi Arabia. So you don't have to go abroad for fellowships. There are a lot of good potential places in Saudi Arabia. All of these subspecialties in medicine have fellowships in Saudi, but it depends on where you want to work and what the hospital's requirements are. So some hospitals will require you to go abroad for a year to come back as a consultant in their institute, but some do not. So it depends on where you want to work. Does the nephrologist or any subspecialty cover other specialties on call? Depends on the hospital, honestly. But for example, when I'm a nephrologist on call, I only cover nephrology. Are you talking? So for that person that asked, are you talking as a consultant or are you talking as a resident? Because the residents, they cover nephrology and gastroenterology during their night call. But as a consultant, no, you only cover your specialties. You don't cover any other subspecialties. How many on calls per month and how long will I stay in the hospital? So it depends on the specialty. So CTU, you have 3 to 4 calls per month, 24 hours. So you come in the morning at 8 o'clock, you do your rounds, you see your patients, you start your call after duty, after hours. You finish your call, you hand over the sick patients. You do not round with your team the next day. You just hand over the sick patients and finish off what you were doing before at the end and leave and go home. You do not attend the next day at all. So it's usually 26 hours maximum. So you start at 8 o'clock and then 8 o'clock in the morning, you hand over to the team. If there's anything pending that you should have done overnight, you would do it, like a note or something for the patients that you've admitted. And once you're done, you leave, right? How's the local programs compared to North America? Honestly, as I said, I just recently came back. It is very promising. Honestly, I'm amazed with the the knowledge and the people in the residency programs here. It is very comparable. There are some minor detail difference. Some are good, better here, some are better there. So honestly, there's not a big difference. But what we want, like what my goal is as a program director, is to take the best of both places and combine them into one good program. Honestly, this is my goal. So there's it is the local programs, honestly, at least in KQH, I cannot talk in other on the behalf of other programs in Saudi, but in KQH, I think it's very comparable and it's really good. And I think with a little bit of effort and work, I think we'll get the best part of both programs and put them in our program. هل بعد residency نصير على طول استشاريين؟ No. So once you finish your residency, you become a senior registrar in the في الهيئة. لازم بعد الهيئة في كل التخصصات سواء medicine ولا غيره بعد the board exam, you stay 3 years as senior registrar and then you become a consultant. However, it depends on where you work, or if you do a subspecialty training. So for example, let's say you wanted to become a general internist and you wanted to stay as a general internist. It depends on the hospital that takes you. So for example, the hospital wants you as a general internist, they can give you privileges as a consultant, but في الهيئة ما تصنف as a consultant until you finish 3 years after your board exam. So yeah, that's how you become because you don't necessarily become a consultant right away. Okay. هل الفشل بعد residency? Yes, it is. So after you finish your residency, during your R4 year, you start applying to the fellowships, and they will take you based whether or not you pass your board exam or not. Yeah, so it is after your residency.
Thank you, Doctor. We received one question from YouTube live stream, اللي هو why burns out rates are high in IM residents.
So you mean the burnouts, right?
Yes, yes.
So burnouts, it's common in all specialties, honestly, not only in internal medicine, it's also in general surgery, plastics. The hours are time consuming, but it all depends on the program itself when they catch it. That's why we're trying to implement steps into detecting burnout a little bit sooner in their training and trying to see how we can help them in the best way possible. It is fairly common in any residency program, medicine as much as any place else, but the trick is to detect it earlier in your residents and try to help them as much as possible. Are there any invasive procedures? Yes. So there are cath insertions and cardiology, like for MIs, cath procedures. There is endoscopies, colonoscopies. There are bedside procedures like paracentesis, thoracentesis, and all that stuff. So there are a lot of invasive procedures depending on what you want to do in your training. Is it hard and tough lifestyle like general systems? Honestly, no. General surgery is very hectic, and they might call you at any time to go to the OR, even as a consultant. So talking about lifestyle after finishing residency, most of your calls you can manage over the phone. Some you might have to come in, but the difference is general surgery, you might have to come in and stay for a few hours in the hospital doing a surgery. So it is not as hard. It is hard, but not as hard. And it depends on like I mentioned before, it depends on what subspecialty you want to pursue. For example, if you choose rheumatology, endocrinology, their lifestyle is very light, very chill. The calls are not very hectic. Very rare occasions where you have to come in overnight. So yeah, it depends on what you want to subspecialize in. What about fellowship? Shouldn't I take it before becoming a consultant? Well, some people do not want to. Some people just like to be general internists, like there is general surgery. So no, you don't have to necessarily do a fellowship to become a consultant. After doing the board by 3 years and becoming a senior registrar for 3 years in general medicine, you become a consultant in general medicine. You don't have to necessarily take a fellowship. Some people take the fellowship because they want to do the training in a specific manner. Like, for example, I want to become a nephrologist. You do have to take the training to become a nephrologist. But if you want to become a general internist, you don't have to do a fellowship for that. What is the chain of command if I'm a junior and there is something I don't know and it's critical? Who do I contact first? Of course, when you're a junior, you contact your senior resident. There's always a senior with you overnight. And if the senior is not available, which is highly doubtful and is a red flag for me as a program director, you call your fellow or your consultant right away. So you shouldn't be put in that situation. So if there's something that you do not know, I would rather you call me for a Tylenol dose or a paracetamol dose rather than guessing, and it may or may not harm the patient. So there is a hierarchy where you call your senior, you call your fellow, you call your consultant, depending on what situation. Is there any news regarding decreasing the residency 2 years to 3 years? I have not heard anything that's happening anytime soon. Honestly, no, I haven't heard anything.
May I have a question? regarding الريسيرشز في الانترفيو, do you prefer انها تكون في internal medicine or it's fine يعني لما تكون من other specialties زي family?
I don't mind. Me personally, of course, every program director is different. I don't mind you doing it anything, because in the end, so the reason people would like it to be in medicine is that if, for example, if you're doing all of your research in surgery and you apply to medicine, it means that your like it shows, not necessarily true, it shows that medicine might have been your second choice or your second options, which you did not want, and you're just stuck with medicine now. So this is the main reason why people think. But for me, the fact that you were doing research as an intern, and the more research, like I would prefer you've done 7 researches or 8 researches in general surgery, like as a person, rather than just doing 1 in medicine.
Perfect. Thank you so much, Dr. Hatem. Anything to add?
No, like I said, so don't narrow your mind. You're in your 5th year. You did your medicine, and I think you're in your surgery rotation right now, and then you're going to do your pediatrics rotation. Keep an open mind to all of the specialties. Don't be narrow-minded from now. Go to your internship here with an open mind. And even if you, inshallah, get accepted into internal medicine residencies, don't go in as an R1 saying, I want to do cardiology, or like, this is my only advice, is that be open-minded and be yourself, because in the end, when we're accepting residents also, we're making a partnership with this person. So I would like to have this person, know this person well enough. I want them to be open with me. I want them to be honest with me, and they will have my full support. So just be yourselves, and Allah yuwaffiqkum, inshallah.
شكرا جزيلا. It was a pleasure to have you tonight.
Yeah, have a good day.
Now we will proceed with ophthalmology with Dr. Asma. Dr. Asma, can you hear us?
أي أهلا وسهلا. هلا.
أهلا، مساء الخير.
طيب سامعيني زين؟
Yes, واضح الصوت.
And you can see my screen well?
Not yet.
I started sharing. I'm not sure why you cannot. 1 second. How can I share my screen?
بس اضغطي البوتم الأخضر.
Share screen and then.
إيه. إذا إنك تختارين على طول على الدوكيمنت اللي أنت فاتحته الباوربوينت مثلاً.
مكتوب screen. Microsoft OneDrive, Microsoft SharePoint.
طيب حطي سكرين بعدين اطلعي من زوم وافتحي
Okay. You still cannot see it?
Yeah, we still can't see it.
One second.
Yes, ظهرت الحين سكرين. واضحة الحين. دكتورة أسماء ما نسمع صوتك لسه، سوي unmute.
الحين تسمعوني؟
إيه الحين واضح بس في صدع لو
طيب تسمعوني الحين؟
إيه بس في صدع لأن واحد من الجهازين بس سوي له ميوت.
كذا؟
إيه خلاص ممتاز.
ممتاز. طيب, let me tell you about ophthalmology programs in Riyadh. Just so you know, I think the ophthalmology program specifically is one of the best among the Saudi Commission programs. It was actually the first program to be accredited. The duration is 4 years across all the programs, and usually they accept around 24 to 25 residents that are nominated, and then about 23 will be accepted each year. The current programs that are available includes KKESH, which is my program, and then there is KSU as well. There is Prince Sultan Medical City, which is a new program, as well as the National Guard Hospital. I think they just started accepting residents. It used to be a joint program, but now they are splitting up. بالنسبة لكيكش, what I like about it and why people pursue it usually, the positives of KKESH is that it has a very collegial environment, meaning everybody's friendly. The residents are kind to each other. It's not that there's no competition, but it's a friendly competition, I'd say. Even among consultants and residents, they treat you as colleagues rather than your senior, which I find very reassuring and supportive. Another thing that people usually pursue it for is the fellowship opportunities. If you are not going to KKESH for residency, you are definitely going to want to go to KKESH for fellowship, because it's the best at fellowship training for sure. It has been training fellows forever. And the chances of you getting accepted into a fellowship program are much higher if you belong to that program. The other thing that I enjoy about KKUSH is that it's also a research center. It has a very good research underground that will facilitate any research you want to partake in. There are good databases for different diseases, retinoblastoma, glaucoma, and so on. So if you need the registry for any list of diseases, KKUSH is great for that. The other thing that we have at KKUSH is a wet lab, and I'll show you later what it looks like, which is a training place for surgery. Another thing that some might consider a negative, to be honest, is that we see a lot of rare cases or advanced cases, let's say. That may be a positive if you are really interested in seeing everything that they write about in the books. KKUSH, think of it as a place of case reports. That does not mean you don't see the basics, but we don't usually admit patients or open files for patients with very basic problems, like, for example, for pterygium, which means I don't see it as much as somebody in another more primary practice would see. For me, I think it's an interesting mix of cases, and I still see the cases I need to see to be a general ophthalmologist. Another downside, a huge downside, to be honest, is the heavy workload, not just during the workday in clinics and ORs, but also during the on-calls, actually mostly during the on-calls. In ORs, sometimes the OR will last over 4 p.m., meaning it will extend to 6, 7, 8, 9. I've stayed up into 11 inside the OR, not because the OR will take long, but because we schedule a lot of patients and some of them can be difficult. The on-calls are also very busy, like I said. We usually take them in shifts. And because we have an emergency room that is dedicated to ophthalmology at KKUSH, we might see from 50 to 100 patients each shift, which is a high number of patients who are only ophthalmology cases. Now, the other huge program that you need to be aware of is KSU. And of course, I'm a graduate of KSU. I grew up there. I trained there as a med student. And so I'm very loyal to them, of course, and I like their program. The thing I like the most about it is that they're very teaching oriented. That does not mean you will not learn in other programs. Everybody will welcome you if you have any questions or if you ask for any discussion. But I think in KSU they are more targeted at residents and students as well, and they will definitely have a lot of scheduled teaching sessions. The other thing that I like about KSU is that you will see more basic cases that you might not see as much of at KKUSH. Now, the KSU board is an excellent addition that you should be aware of, not just for ophthalmology, but in general, for any specialty. Usually at KSU, they have, besides the Saudi board that you can get after residency, is the KSU board. And that is an excellent backup to have. For example, if you don't pass the Saudi board, God forbid, you can still get the KSU board, graduate, and apply for fellowships without wasting a whole year of your life. I hope this point gets across because I was not actually aware of this. And some people do, in fact, not pass the board, and they have to waste a whole year and apply again in another year, while others at KSU, for example, have the option of applying with a KSU board, even if they don't pass the Saudi board. Now, compared to KKUSH, I'm not saying they don't see as much patients, or it's just a bit more manageable as a workload. You will not, I doubt that they will stay until 10 p.m. in the OR at KSU. The on-calls are also a little bit more manageable. You will become a second on-call very fast in your second year, and then in your third or fourth year, you'll become third on-call. That means your on-call load will decrease. You will be home on-call after 12 as a second, and then third on-call will be totally home on-call. While at KKUSH, all of our on-calls are in-house. Only as a senior, you'll get to leave after 12. Now, in Prince Sultan Medical City and National Guard Hospital, it's a very new program. National Guard, I think, have their first batch this year, and Prince Sultan Medical City started accepting residents, I think, last year. So it's too new to tell you much about it. But what I advise you to do to compare programs, and that's what I did, was talk to residents from each program. That will give you a very good experience overview, and give yourself a chance to try it for yourself. So if I tell you that KKISH has a heavy workload, that's my own experience, and a lot of others, to be honest. But that's my experience. You should give yourself a chance to experience it on your own. So if you ever have a chance to take an on-call during your elective, and I'm sure all of you are thinking of electives, I really advise you to attend at least 1 or 2 on-calls to see what the workload is like. And I'm saying on-calls because most of the job workload comes from on-calls, at least for me. Most of the most exhausting part of residency for me are the on-calls. So it's very good if you have a sneak peek into what your future would look like. And that would enable you to compare programs more fairly. Now, another thing you would think of is the availability of specialties. KKISH has almost all the specialties. The only thing we don't have is a good medical system that allows us to admit patients who are medically unstable. So we don't see as much unstable patients as KSU, for example. KSU as well covers all of the specialties that you need to see, as well as National Guard. I'm not sure about Principal Medical City, but they usually will do outside rotations if you ever have a deficiency in one specialty. For KKISH, for example, we do a rotation at King Saud Medical City to see more open globes and trauma cases. This is the wet lab I told you about. Our wet lab is something that our program director started, Dr. Sami Shahwan, and we are very grateful. As you can see, we have surgical equipment similar to the ones we have in the OR, surgical microscopes, surgical instruments, phaco machines. Phaco is the cataract surgery that we do. It's our bread and butter. And we have a lot of phaco machines there, old and new, so that we get to experience both, as well as suturing equipment. And then we have also a simulator, like the one they use in airplanes, to drive airplanes, simulators for surgeries, different surgeries. That way, when we go to the OR, we are very confident that we have had a little bit of experience before starting to work on real patients. Now, what are the positives of ophthalmology? Why would somebody pursue ophthalmology? For me, I'm a very visually oriented person. That means I like to see with my eyes, diagnose with my eyes, and if you are one, you're going to enjoy ophthalmology because everything we do is clinical and visual. Another thing I like about ophthalmology is that there is a full spectrum of treatment and intervention. For example, if you think of diabetic retinopathy, primary intervention would be to, for example, control diabetes to avoid diabetic retinopathy, which is a huge cause of morbidity in our kingdom. Secondary would be screening the patients with imaging. Tertiary would be to pick up those patients with diabetic retinopathy and treat them. And then tertiary is, for example, visual rehabilitation. So they are blind now, they have very limited visual field, but you will give them glasses and visual aids to help them move around. Another thing that is usually said of ophthalmology is that it is a medical and surgical field, meaning it's mostly surgical. So if you go into ophthalmology thinking you're going to avoid surgery, that cannot happen because in residency, you're definitely going to need to fulfill your surgical logbook. But in the future, say, for example, for whatever reason you wanted to stop surgery, that is an option. You can pursue, for example, uveitis. You can pursue medical retina. And as well as what else? Neuro-ophthalmology. All of these specialties are purely medical in ophthalmology. The rest of the specialties are all surgical. Another aspect that is special to ophthalmology is microsurgery, and I'll show you in a minute. We deal with huge magnification to operate on very small structures to treat blindness in general. And that is something I enjoy personally. Financial reward is special to ophthalmology because it has a high turnover, meaning the surgery doesn't take long. And they will pay a lot for it, which means if you do pursue a surgical specialty, and that's where the income usually comes from in any specialty, is that it's procedure generated. The more procedures you do, the more money you'll make. So usually it's financially rewarding. The lifestyle, at least as a consultant, is usually very nice and comfortable. You will not be called into the hospital after 4 p.m. or after the workday unless there is open globe, most likely. Of course, that depends on the practice you are joining, but in general, it's a very cushy job. Not as a resident, though, at least not in my program. Now, like I said, this is one of the wet labs we did. This was actually at KSU. We work on goat eyes to practice phacosurgery. Now, the negatives or downsides of ophthalmology, I actually struggled to come up with negatives for ophthalmology. That's how much I love it and how much other ophthalmologists love it, because you can't really go wrong with ophthalmology. But there are, of course, negatives. This includes office routine. If you are somebody who likes to see a lot of organs or likes to do something different each day, tough luck, because it's a bit, you will definitely experience the routine in ophthalmology. You will only be looking at one organ twice. So that can be a bit dull if you are not comfortable seeing things again and again and again. It's very competitive. I think this is one of the biggest negatives for ophthalmology. And that was very exhausting for me during internship to try and fulfill all of the requirements to get into it. It's a saturated specialty in general, meaning you will not be guaranteed the job that you desire as much as, say, if you join something like obstetrics and gynecology, where there is definitely a demand for consultants. It's a steep learning curve, and I usually like to compare it to dentistry. Imagine if you join dentistry after finishing med school. Everything will be new to you. Yes, you've heard of teeth, you have seen teeth, but you have not known them until you start residency. And that's the thing about ophthalmology. You know that there are eyes, you have seen them before, maybe you touched the torch once or twice, but you have not experienced it at all during med school. So you'll be learning everything from scratch. Back problems and ergonomics are very problematic, to be honest, for us, because we sit all day at the slit lamp and then we sit all day at the OR. And so you have to maintain a certain posture all day, which can take its toll on your back and neck. And from what I've seen, a lot of ophthalmologists, and this is a well-known problem, have back problems or neck-related issues. Some of them even started physiotherapy, actually, after starting residency because of this. This may not be as much of a problem when you're young, but as you get older, I've actually seen surgeons with back braces in the OR. Like I said, it's a very confined specialty. So if you really like the rest of the body, then don't join ophthalmology, because you'll be giving that up. No more EKGs, no more stethoscopes. I lost my stethoscope in internship here and I never bought one again. Now, the typical schedule for a resident, of course, varies, depends on the program that you join, but usually most of the on-calls are in-house for KSU and KKISH. We usually have 2 ORs per week and 3 clinics. The clinics, if they are a full day, will be from 8 to 4, maybe a little bit longer if it's busy, up to 5 or 6. And we have a half day for the grand round every Tuesday. For a consultant, the job is much more flexible. You will have home calls for sure, and usually they will not call you unless there is open globe, which is not as common as you'd think. They will also have like around 2 clinics or 3 clinics, and their job usually allows them to join private practices if that's your intention. Now, the traits that are required in an ophthalmologist. What makes you a good candidate for ophthalmology? These are things you need to look for in yourself and evaluate yourself if you think you can fit this criteria. The Saudi Commission health specialty requirements are definitely the most important. If you can't fulfill them, it doesn't matter how great you are. Even if you invent a cure for all causes of blindness, you will not get accepted unless you match or get nominated, I mean. So you need to work on those and acquaint yourself with the most recent requirements and make sure that you fulfill them. For GPA, that is a done deal. So as fifth-year students, and I'm imagining that almost all of you are fifth-year students or interns, am I wrong?
Right.
GPA is already fixed almost, so there is not much you can do about it. But what you can change is your SMLE score. So think of SMLE as a second chance. So if you didn't have the best GPA in school, I didn't have the best GPA in school. But if you didn't have the best GPA in school, think of SMLE as a chance to make that up, to make up for that. Another important thing is dexterity. Don't worry, the residency program will teach you everything you need to know about surgery, but there is a certain level of dexterity. What I mean by dexterity is hand skills that is required. You don't need to be the best, like I said, they will teach you everything. Even if you have a fine tremor, especially when you're nervous, everybody does, that is acceptable. But if you have a very noticeable deficit, let's say, or tremor, very coarse tremor, then maybe ophthalmology is not the best for you because you will struggle in surgery. Another thing that I think interns usually miss, and unfortunately we've had examples where candidates, excellent candidates, were rejected or not accepted or not matched because they had some sort of amblyopia problem. What I mean by amblyopia is كسل العين. One eye is not seeing as well as the other. That means you don't have binocular vision. You are only seeing or depending on one eye. That means your depth perception or stereopsis is off. And you need good 3D vision for surgery because we use microscopes, and we also need it for the slit lamp. So you'll really struggle if you don't have it. And they actually screen for this, as well as color vision. They usually screen for this after the residents are nominated. So my advice to you is, if you are ever during an elective, if you ever find yourself doubting this, you should get checked. You can ask any resident, you can ask me, I don't mind, you can contact me later if you want to check your 3D vision. I'd be more than happy to. The kit on the top right is what I'm talking about. We use special glasses and evaluate your 3D vision, as well as color vision, because some individuals are not picked up until they are adults. It can be missed. Now, things you can do to increase your chances of acceptance. Some of them are pretty obvious, like volunteering, for example, and research. These are important in any specialty, not just ophthalmology. I know that ophthalmology really likes to look at research, especially original articles, not just case reports. And if they're published, that makes it even better. Now, surgical courses, there are two courses that I can recommend, which is the BOSS course, which is more targeted at GS, to be honest, than ophthalmology, but it will teach you the basics of suturing, of scrubbing in, of handling tissue, and I think it's very beneficial if you can get it during your internship. That would be great. Another course that I'll recommend, although you need to book it really early in advance because it has only 6 spots, and I think it only gets done 4 times a year. This is done at King Faisal Specialist Hospital and Research Center. And the bottom right image is one of the repairs we did during that course. We use very small sutures. So we start with 4-0, then 5-0, then 6-0. So the bigger the number, the smaller the suture, up until 10-0 or even 11-0. In ophthalmology, just to give you a reference, we usually use 10-0 for most of our cases. So these are the courses that I can recommend. Now, if you match, what's the next step? Is the interviews. What I can recommend is that you think of them as two stages, pre and the day of. Pre, you need to think about doing electives. That's when your interview actually starts. Know your CV very well and practice with friends, family, and somebody you're comfortable with, and then somebody you're not comfortable with, to simulate the real environment of an interview. The day of, make sure you make good eye contact, a cool demeanor, that you don't show that you're nervous. I've actually seen the evaluation sheet, and one of the things they look at is if you have any nervous tics, for example, if you twiddle with your thumbs, if you play with your necklace, or so on. You need to dress well, but don't do anything drastic. One of the stories I always tell is that I tried to change my shoes the day of before the day of the interview, because I thought my favorite flats, which I was going to wear during the interview, made a bit of sound when I walked on hardwood floors, and so I sent it to get repaired, and unfortunately it came back ruined, and I had to buy a new pair, and it was very uncomfortable to the point that I had to take them off during the interview. And when I tried to find them again under the table, I actually couldn't. So that was a bit awkward. And I realized that I shouldn't have changed something so late. So dress as you usually do. Try to stand out in a good way, not for your fashion sense, but for your CV, for your charming personality, and so on. Now, electives, to make the best of it, think of it as targeting the right time, the place, and the person. Time-wise, avoid them during your quiz exams. If you have a huge assembly exam coming up, this is your last chance, then don't do an elective during that time, so that it doesn't interfere with your performance. Like I said, the interview starts from the elective. The right place, you need to join the right place. For example, the programs that you're thinking of, you need to go to them. And then with the right person, so not just the program director. You can join somebody else who's usually joining the interviews, and you can ask around or ask the last batch who attended the interviews. It's nice to have interesting hobbies. I think the thing that made me stand out the most were actually my hobbies, and they think of me as the girl who plays Taekwondo. So that was one of the things I said, that I play Taekwondo, and that's one of the things they remember me by. Reading is also, for me, a special hobby, but if you have something else, I think it would be nice to introduce, especially if it is related to hand performance. For example, if you are good at art or something that shows you have good hand skills, it's good to showcase that. For me, I actually brought my art portfolio and showed them some pieces of my art. And I like to think of hobbies as three parts. So it's good to have one that is physical activity related, one of them that is mental or like, for example, reading, and one of them that is artistic. If you have like a good roundup of hobbies like this, I think it would be really nice to show that you are a well-rounded person. Now, this is one of the tools that I used as an intern to choose the right program. This doesn't apply now, but what I did was give a weight to each variable you see on your left hand. For example, teaching was very important to me, so I gave it 3 points, but for example, the location was not as important, so I gave it 1 point. And then I scored each program and multiplied that by the weight, and it gave me a final score. That I don't actually depend on the final score, but filling out this sheet actually helped me make the decision to join KKESH, so that I know what things I care about and I know where to look for them. Now, if you do not match, do not despair. There are options. The first thing you should consider is option B, or your backup plan. So if you don't like ophthalmology, if ophthalmology did not exist, do you see yourself somewhere else? You should think of that. You should sit down with yourself and think of the second option. And if that option is competitive, you definitely need to prepare for it as if it was your first. Another thing you can consider is go to another city that is less competitive. But think of the quality of the programs if you go outside of Riyadh. A clinical attachment, some hospitals offer that, and service, although I do not recommend spending too much time in service, because usually your chances will decrease each year. If you do not match this year, the trend is that the scores will go up next year and the year after that, so your chances will be actually dropping. So unless you get the 2 points from service and that works for you, the odds are probably not in your favor. Although there are some residents that we've heard of that have joined the program after 3 or 4 years of service. Another thing you can consider is academics. So for example, doing a master's of public health or so on, and then consider rejoining the program. Now, the resources that I really enjoyed as an intern were these 2 books, the Choosing a Medical Specialty The Ultimate Guide to Choosing a Medical Specialty, which talks about each specialty in detail, and I found it very useful. The other thing I liked was tips about interviews from program directors from Kaplan. Now, if you ever need anything, if you have any questions that I have not answered today, you're more than welcome to contact me or reach out. And if you want to take a tour at KCASH or see the wet lab, I'd be more than happy to show you around. Just reach out and let me know.
Thank you so much,
do you have
Dr.
any questions?
Yeah, we already received some questions, Kenny. I will read them for you.
Sure.
So first question is, what are other choices if we didn't get accepted in ophthalmology, master or residency in different country? Which suggestion, if there is any? I think you just mentioned some of them, right?
Actually, there are more. Besides going to another city, you can go to another country. I've met more than one resident or one fellow or one consultant who have done their residencies at a French program.
Oh.
So you definitely can consider that. You need to look into it. I asked them about their experience. They seemed to enjoy it overall. They had a good surgical exposure, but just make sure that it is accredited by the Saudi Commission.
Yeah. Other question, can you please talk more about KSU board?
KSU board, okay. So like I said, once you graduate residency, you will take the board, correct?
Yeah.
If you do not pass the board, the written part especially, the oral board is fine, but the ASCII is fine, but the oral board, if you do not pass it, you're going to have to take it again in another year, which means a whole year wasted because you did not pass the board. The perks of having a KSU residency is that it qualifies you to enter the KSU board. So only KSU residents can enter the KSU board. Say, God forbid, somebody doesn't pass the Saudi board, which is, I guess, tougher than the KSU board, then you have the backup of using the KSU board to apply for your fellowship. What does that mean? You go to the KSU board with consultants you probably know, you know what they care about, so you can pass the board and use that to apply for fellowship instead of waiting a whole year. So some consultants who have graduated now and lived on happily actually only pass the KSU board, not the Saudi board.
Perfect. وده هذا ما يأثر يعني على الابلكيشن للفellowship سواء إني معي كان سواء apply with KSU board or
I've seen fellows apply with the KSU board. Some actually apply with the Arab board. After finishing the Saudi board, they do the Arab board. But KSU is a much better option. It's good to have that backup.
Perfect. Another question, what do you mean by second and third on-call?
The on-call system, how it works is that there will be a first on-call or a junior. That would be the first person they contact when a patient arrives. The second on-call will usually be a senior. For us at KCASH, we have a junior and a senior who are both present in-house in the ER at our hospital up until 12 at least. And we work in shifts. So up until 12 will be one junior, and then after 12 will be another junior. But the senior will be 24 hours. This is for KCASH. For KSU, their system is a little bit different. The first on-call will be an R1. The second on-call will be an R2. And then I think R3 and R4 or R4 will be third on-call, which means that they will first contact the R1. The R1 will be in-house. And the second will be in-house until 12. The third on-call, who will be an R4, will be home on-call. You may not care about this now, but when you are studying for the boards, you really don't want to be taking on-calls. Okay. So that makes a lot of difference.
Yeah. طيب في سؤالين عن المعدل. First question, if I score high enough in SIMILE to get me in the first match, but my GPA is below 4.5, would that affect the center's opinion in choosing me? If yes, which centers care the least about GPA?
Everybody cares about GPA. I'm sorry to tell you this. I actually asked the program director about this, and they said they look into GPA. But remember, they know that every college has a different average, meaning some will have higher GPAs on average than others. So if that was the problem, I know some colleges don't usually give out grades and they're very stringent with it. So if that was the problem, then I guess it can be explained. يعني أنا أعرف واحدة من البنات بالانترفيو قالوا لها أنت من الحرس أنتوا تعطونهم درجة، أنتوا يعطونك درجات، الجي بي حقك مو بصدق كذا، صح ولا لا؟ ف they have this idea. بس الجي بي أصلاً يعني they will think of it. They might ask you about it, and I had my own answer to get around it. يعني maybe you can use that in the interview. دكتور الفواز وكم واحد من KSU سووا research عن الجي بي and how it predicts resident performance later on. And they found that it does not correlate to performance later on. So I had that answer prepared. But below 4.5, you need to have an explanation if they ask you. For example, wallah, that was a tough year for me and I overcame it by doing so and so. Usually if you can explain it away, that's not a problem. If your SMLE can make up for it, if your what do you call it? If your CV can make up for it, then it's not as much of a problem as you think it is.
Perfect. في عندنا كذا سؤال برضو عن ال GPA. Is GPA 4.5 reasonable for applying يعني from the first place?
يعني لا تخلون أحد يقول لكم إنه you cannot apply to ophthalmology. يعني أنا كنت يعني من الأشياء اللي كانت تحطمني إنه كانوا يقولون لي أوفثا بس للدوافير، وأنا شاطرة بس الجي بي اي مو على شيء، فكنت أحس إنه خلاص ما في أمل. And that is not true. You need to give yourself, especially if you're interested, you need to give yourself a chance to join. عطوا نفسكم فرصة. الSMLE, think of it as a second chance to make up for it. Why not?
برضو هذا GPA question. Is a second degree honors with excellence good as GPA or bad for ophthalmology برضو?
I think it's good. Okay. I know some have second degree, second class honors.
Perfect. Is there a wet lab in KSU?
I think they're working on it. You just reminded me. I think KSU really care about GPA. I think the program that cares the most about GPA is KSU. Because all of the residents have the highest GPAs. I know KSU is working on it, but I don't think they have one just yet. KKISH is already well established and we have over 12 microscopes.
ممتاز. في سؤال يقول let's say I matched but I didn't have of the research done. ممكن تتوقعين هذا الشيء يأثر كثير خاصة في المقابلة؟
I'd say if you are asking this question, then go and find the case report to work on. Case reports can be finished very quickly, and at least you'll show that you are interested in ophtha in each part of your CV. If I show you my CV, you'll see that there is something about ophthalmology in each section, in research, in awards, in electives, in research, in presentations. It's not, they will not exclude you for it, especially if you have research in other specialties that is published. I think they care about being published more than they care about the topic itself, but they will not ask you about another specialty. They will not discuss with you your research as much.
Okay.
يعني أنا مرة سويت psychiatry research. لما قلت لهم أنا psychiatry حرفياً their eyes glazed over. They're not interested at all in other specialties.
Perfect. If you are nominated but not matched, what will happen to you?
Why were you not matched? That's the question you need to be asking, to be honest. Did you not match because you have a deficiency in the CV, because you did not show interest, because you had like poor vision, or like I said, color vision problems? You need to be asking yourself that. Of course, you will not join a program that year. There is usually no second match. That's the Saudi Commission program. That's how it works. There no longer is a second match. But you can think of the other options that I told you about. You can apply next year or join the other programs, like I said.
ممتاز. نرجع للانترفيو. إيش أكثر شيء يعني they look at هل الريسيرشز ولا الكونفرنسز ولا recommendation letters؟
I did not want to waste time much on interviews. I'm sure somebody else will talk about it. But since you asked, I think this is very important. I usually give talks actually about this because it's such a waste to match to be nominated into ophthalmology and then not match.
Yeah.
What was your question specifically?
إنه إيش أهم شيء يناظرونه في الانترفيو؟ هل الريسيرش conferences or
I'll give you a tip. Like I said, and I've seen the score sheet they use in the interview, how they score. And they have different parts. The candidate looks comfortable, the candidate looks well-dressed, reasonably. إذا ما كان عنده visible disability, like for example, let's say strabismus, exotropia. This means you're not seeing well with both eyes. They will mark you down for it. And then if you respond well to stress, if you respond well to الاستفزاز اللي يسوونه بالinterview, all of this is important. But like I said, it's nice to have interesting things to talk about. And where will the questions come from? Where do you think? From the CV, for sure. They usually read your CV before you come in. One of the interviews, they actually greeted me by asking me about Taekwondo. That meant that they read my CV before I came in. So the questions will come from your CV. So you basically know the interview. For me, there were things that I wanted to discuss with them. And so I intentionally put them in the CV. For example, the Taekwondo and the graphic art, I brought my portfolio because I knew they will ask about my work. If you have a skill, if you say, for example, you know calligraphy, you better be able to demonstrate that skill on the table. So if you say, أنا مثلاً قلت لهم إني أرسم وما كنت أبي أرسم قدامهم. I don't do well under pressure like this. قلت لهم إنه والله art is an inspiration, it doesn't come on demand وما أدري إيه. كنت أحس إنه خلاص بسكر الموضوع. قاموا قلبوا الورقة قدامي وقالوا يلا ارسمي قدامنا. طبعاً let me tell you that was the ugliest piece of art I've ever made. And I don't blame them for mistrusting me if they don't think I made that art myself. But that was a good experience because it told me that they will always ask you to demonstrate the skill you say you have. إذا أنت تقول أنا خطاط ورهم الخط اللي أنت بتوريهم. حتى أنا actually كنت أفكر إني أحط الكاليغرافي بالسي في وقمت أتدرب على أسماء الدكاترة اللي بيجون بالانترفيو. بعدين هونت قلت لا خطي مو بأحسن شيء.
Perfect tips. طيب, what should we wear during an interview? عباية or scrubs?
لا سكرابز ولا عباية. طبعا كويس تشوفون الباقيين ايش راح يلبسون. أنا دفعتي الأولاد كانوا يلبسون ثوب وشماغ. البنات كانوا يلبسون لاب كوت وسكيرت. I think you can also wear smart pants. A nice flats. بس لا تسوون غلطتي يعني وتحاولون تحسون فيها قبلها بيوم. ولاب كوت عادة. عباية ما شفت أحد صراحة يلبس عباية بانترفيو. Scrubs no. For male or female no.
تمام. Do you have any idea about the residency in Germany?
To be honest, no. I have not met any graduates from Germany, but like I said, I've met graduates from the French program.
ممتاز. Can you tell us about lifestyle as a female when it's a residence fellow and consultant? Briefly.
طبعا أنا تزوجت ترى بالرesidency. I didn't think that was possible, but I did. And I know some of my colleagues who've had babies during residency. I know they are struggling, especially at KKESH. I don't know as much about the KCU program, although I know one resident who also gave birth during her residency. It's not impossible. It always depends on the person. But you'll definitely need to sacrifice something. So you'll not be spending as much time with your family, of course. You'll definitely need some help taking care of them. أنا أعرف واحدة من الconsultants تقول كانت جايبة بيبي في الريزيدنسي وبيبي في الفellowship. تقول أول بيبي هذا مو حقي، بيبي الريزيدنسي هذا بيبي أمي، الثاني هو البيبي حقي. لأن ما كانت involved يعني in taking care of them as much. بس مثل ما قلت لكم people do it. It's not impossible. GS مثلا أتوقع أنه near impossible ولا أوبيجايني. Ophthalmology it can be done. It's not encouraged but it can be done.
ممتاز. نرجع لل GPA question. If my GPA is than 4, can I be accepted?
If your GPA is less than 4, but your SMLE is 100, you probably can. Nobody can tell you this will not be accepted, but it will definitely be an area of question. So if you can explain it well, if you can say, this is the reason my GPA is not as high as you'd expect it, and this is how I overcame that problem. هم يبون أحد عنده مشكلة مثلا بالاختبارات وما ما عالج هذه المشكلة. But if you show that you overcame that problem, then that is excellent. I think it's not as much of a problem. ومثل ما قلت لكم يعني أنا personally I was prepared to answer it in a more evidence-based medicine kind of way, which is by quoting their own research back at them.
ممتاز. Question: Can you talk more about Prince Sultan program? We could سأل السؤال يقول I couldn't find enough information, or if there is a resident there we can ask.
في أنا عارف واحدة اسمها بيال المسعودي ومعها 2 residents I think أو شيء زي كذا اللي قالوا لي إنهم يعني أغلب الروتيشنز الموجودة هناك. They seem to be enjoying the program, and like I said, most of them will do outside rotations. يعني كل هذه البروجرامز اللي قلت لكم إياهم كلهم يجون ترى في كيكش، كلهم يجون في الER mostly يعني. كexposure like I said, it's too early to determine the outcome. ما أقدر أقول لكم إيش نتائج البروجرام حقهم لأن لسه ما حد تخرج منهم. The oldest batch is R2 now.
Okay.
National Guard, the oldest batch is R1. So I can't, in good faith, give you a good picture without seeing the product of their program.
Okay.
Last question. But you can ask their residency.
Yeah. آخر سؤال اللي هو هل قصر النظر ممكن يأثر على القبول؟ الساعة اللي يلبس نظارات يعني.
أنا ترى ألبس نظارات. أنا ألبس نظارات بس ألبس كم -2.
Okay.
بس مثلا visibly high myope مثلا -12 -15 كم البريسكريبشن. actually أنا كان سألوني بالانترفيو كم البريسكريبشن حقتي. وباي ذا واي يعني ophthalmologist can guess your prescription. أنا from looking at your glasses I can tell if you are a moderate myope زي يعني -2 ولا high myope -20 from the thickness of the glasses and the effective minimization that it gives. بس نسألوني مثلا just to see how I respond. أنا جبت لهم إياها زي ما تنكتب كprescription أو DOS sphere axis cylinder. فمثل ما قلت إذا ما في very high myopia مسوية disability ما ينفع.
ممتاز جدا. I think this is all the question. Any advice for future who want to be ophthalmologist?
ركزوا على الكرايتيريا حقت الأكسبتنس مثل ما قلت. يعني even حتى لو أنتوا أفضل candidate أفضل إنسان بالدنيا وكل البروجرام دايركتورز عارفينكم وكلهم يبونكم, if you do not get nominated from the pool, there is nothing they can do. Nothing. ما البروجرام دايركتور ما في شيء بيده يخليه ينط على السعودي كوميشن ويخليهم يدخلون اسم واحد مو موجود بالسيستم. فأهم شيء تركزون عليه هذا الشيء. Second is electives عشان once you get nominated you secure a good position. فتأخذون electives بس in the right time.
ممتاز بإذن الله. شكرا جزيلا على نصائحك، شكرا على وجودك معنا.
الله يعافيك يا رب يسلمك.
ما قصرت.
أبد إذا أي أحد عنده سؤال مثل ما عندكم إيميلي
بإذن الله. I will share it في
Sure, no problem.
Thank you so much.
يعطيكم العافية.
الله يعافيك. Thank you so much for all audience and see you tomorrow inshallah.